So it's now my pleasure to introduce our speakers for today. So Dr. Dina Henshaw is well known to all of you, and Dina is a family physician as well as a specialist in public health and preventative medicine, and is currently the Chief Medical Officer of Health in Alberta. Dr. Jeff Kwong is also a family physician and public health physician, and he's based in Ontario, where he's a scientist at Public Health Ontario. Jeff is also a lead for ISIS in a program for populations and public health, and his specialty is in the area of infectious disease and vaccines. So I want to put out a very warm welcome to both of our speakers. And as we do with all of our certified programs, it's important for us to review our conflicts of interest declarations with our audience. So Dina, I'm going to ask you to go first with a quick hello and then review your disclosures, please.
Sure, thank you. So I appreciate the invitation. Thank you for the opportunity to be here. The only conflict of interest, or the only disclosure I would make, which isn't written on the slide, is just that I am an employee of the government of Alberta, but otherwise have no separate funding sources and do not gain financially from any kind of private enterprise related to coronavirus.
Jeff, why don't you go next?
Yeah, so I received salary support from ICES, Public Health Ontario, Department of Family and Community Medicine at the University of Toronto, and the Toronto Western Family Practice Associates, where I am a family physician. And my grants I received peer-reviewed grant funding from CIHR for my research.
Thank you very much. And my disclosures are there as well. I am a paid employee of the College of Family Physicians of Canada, where I am a physician advisor in CPD. I also receive a stipend from McMaster University's Center for Simulation-Based Learning and from the Department of Family Medicine there, and receive honorariums from Ontario College of Family Physicians for teaching activities that I do with that organization. So Brian, next slide, please. So as well, this program is just to be clear to our viewers, this program has not received any financial or in-kind support. And the questions that we're posing today at the start will have been developed by our staff from the CFPC, as I mentioned earlier. And any recommendations are certainly based on evolving evidence, and the situation is, as we all know, is ever changing in this pandemic. Next slide, please. So during this webinar, our goal really is to review a few things with respect to understanding the disease cycle, understanding the current impact that this whole pandemic has had on Canadians with respect to public measures, as I said earlier, that have been rolled out, to discuss the impact on our entire healthcare system, and also to certainly think about some things in the future with respect to other measures and certainly around the area of vaccines. So those are our learning objectives for today. And with that, we can get into our questions. So the first question, I'm going to start with Jeff, and I'm going to ask Jeff if he can comment on any sort of new information about the patterns of this viral spread. And certainly we're seeing a lot more in our communities as far as transmission person to person, and in certain populations like the elderly and our nursing homes.
Mm-hmm. So I mean, now that we've had most of our travelers return to Canada already, we're not seeing so much in travelers anymore, and unfortunately now we're seeing more outbreaks in institutional settings. So long-term care facilities, retirement homes. I think these are the areas where we're going to be seeing, where we are already, and we're going to be seeing more and more outbreaks, as well as homeless shelters as well, because it's very hard in these settings to do the physical distancing properly. And then also, we've closed a lot of the long-term care and nursing homes to visitors, but I think staff may be coming in, or new patients coming in who may have been infected and are incubating and then transmitting to others. And so I think this is an area where we need to do a lot more public health measures and infection prevention and control to try to mitigate the spread in these settings.
Yeah, thank you very much. Dina, if you certainly can comment on that population as well, but also about our younger population. We're not, if we're not seeing these younger cases, is it because they are truly resilient? Or are they avoiding testing, or perhaps just not symptomatic enough to be counted? And certainly we know that in high dense, low income areas, younger people are still at risk.
Yes, that's a good question. And part of the reason that we're seeing less cases in young people in our case counts is partly because of our testing eligibility criteria. So in Alberta, we did quite a bit of testing on returning travelers for the first several weeks of our epidemic when it came to our province. And we did see cases in younger age groups. At that time, we were testing anyone who'd returned from traveling. So that did include children and young adults. And when we shifted away from travelers, because we had implemented requirements for them to be in quarantine for the first 2 weeks after they returned, and we wanted to use our testing capacity to look more at local transmission. So we started looking at healthcare workers and also looking at those who worked in or were residents of long-term care and congregate care facilities. Of course, then children did not fall into the eligibility criteria at that point in time. So part of our ability to detect confirmed cases is really about who we're testing. And also it does seem to be the case in reports that have come out of China, and certainly a case series that was published by the US CDC, that children do tend to seem to have milder symptoms. That does not mean that children are immune to this or that they cannot have more severe illness. So certainly it seems there's some emerging evidence that perhaps children under 1 year of age, within that group of children, the youngest do seem to have a slightly higher risk of having more severe disease. And of course, children who have chronic conditions would also potentially be at risk for more severe disease. So this is an emerging area, and we're continuing to watch it very closely. And in Alberta, we have just opened up our eligibility this week to anyone who has any symptoms. So we'll be watching very closely to see what our numbers in children look like as we go forward with our current testing.
Thank you, Dina. That will be very interesting to see now that you have opened up testing to anyone with symptoms. That I think that's really the hope for many provinces and jurisdictions. So speaking of some of these healthcare measures, with certainly with our physical distancing, hand washing, and isolation, as you've mentioned, after coming back from traveling or after exposure to a case. Jeff, is there evidence that these measures are actually working? And if so, how well are they working? Jeff, I think you're muted.
Sorry about that. Yeah, someone was walking by earlier. I had to mute it. Yeah, so I think there is pretty good evidence that they're working because we are seeing, slowing down in the rates of cases. And, I think that the ones that are probably the most reliable are the cases that we're seeing in the ICU and in hospitals, because that's where there's less bias in terms of missingness of who we're getting. But those are lagging indicators. So those are, generally a few weeks later than reported cases. And so, and the problem with reported cases, it depends on who you're testing and how many tests you're doing. So, but I think using all the indicators, we are seeing decreases, which is, a sign that the physical distancing measures are working. The problem is that there are, what we do today, we won't see the effect of that in, 1, 2, or 3 weeks. So, so I think we have to keep it up for the time being.
No, that certainly is the consistent message and certainly makes a lot of sense. And Dina, so what percentage of the population actually needs to comply with these interventions in order to really have a meaningful flattening of this curve?
So it's a good question. And the interesting thing about these kinds of measures is it's hard to put a specific percentage on that, because it's not like a vaccine where if you get a particular percentage of the population immune, there's herd immunity. But these distancing measures don't work like that. So what I would say is that it really is proportional. So if you have a particular proportion of your population following these measures, you're going to be flattening the curve to some extent. And the more of the population that is doing these measures, the greater proportion of the curve that gets flattened. So it really isn't kind of one cutoff point. It's rather that the curve shifts in proportion to the number of people who are following these measures. But I will also comment on something that we've seen with this and other coronaviruses, which is the phenomenon of super spreader events. And so it is possible, even if you had, say, 90% of your population following these measures, but the 10% that weren't all congregated very closely together and then dispersed, you can have super spreader events where one infected person can infect tens or even hundreds of people in one particular event, which is why social gatherings or mass gatherings is such an important part. Limiting those events is such an important part of our strategy right now. So that's not a simple answer, but that would be kind of my overall assessment.
No, absolutely. And as you said, I mean, there are so many variables, and it's a moving sort of target. Any idea how long it would be before we actually see a real meaningful effect? And really, what does meaningful mean?
So as Jeff mentioned, because the incubation period from exposure to someone developing symptoms can be up to 2 weeks long, it's an average of about 5 to 8 days is when most people would experience symptoms, but it can be earlier, it can be later. So when we do implement a measure, it does take a couple of weeks to see the impact of that measure in our case counts, and can take even longer to have an impact in our hospitalization data, because people typically end up, those who do need to go to hospital, often it's within about a week after their symptoms start. So it does take several weeks to see the impact. And as we're thinking and planning forward about a time when we might be able to lift some of these measures, we would have that same need to make sure that we're watching for a few weeks after we change or lift measures to make sure that we haven't gone too far down that road, and we'll calibrate as we go.
Yeah, absolutely important. And along those same veins, when you're talking about lifting and determining determining next steps, what does determine whether a public health intervention is recommended versus actually enforced? Is there determinants around that?
So maybe I'll start, and then Jeff can add any additional pieces. But what we've done in Alberta is we have created legal requirements for what we consider to be the core of our response. And so that includes legal requirements for people to be quarantined if they are a close contact of a case, or if they're returning from travel outside the country. And it also requires them to be isolated if they are ill, particularly if they have a diagnosis of COVID. We have legal requirements for restrictions on mass gatherings for the kinds of businesses that can or can't be open. And there's quite a few legal requirements around operations of our continuing care homes, as we know that seniors who live in congregate settings are some of the highest risk for severe outcomes of this illness. So again, what we've chosen to do is those legal requirements really form the base of our response. And then over top of that, we overlay recommendations that are what we would want the general public to follow. And some of that is actually supportive. For example, businesses who need to close, sometimes it's actually helpful for them to have a legal requirement, because it does help them access, for example, insurance payments, as opposed to just making a recommendation. So sometimes we do make something legally required in order to, first of all, make very clear what needs to happen, and second of all, can actually help those people who are implementing the requirements to make sure that they have all the supports they need to do the right thing.
Great. Jeff, over to you.
Yeah, I'm not sure I have anything more to add to that, other than, like for the public, I think, there are lots of things we can encourage people to do, such as, frequent hand washing, and then the next question where we're going to talk about masks, and just the physical distancing measures that it's up to everyone to do. Like I know we're telling people stay home unless you have essential tasks you have to carry out, such as getting groceries or getting medications. But even when you are doing that, you need to not go chat with friends while you're out. You just go get what you need and get back home, sort of thing. So these are things that we can't enforce necessarily, but we can highly recommend.
So Jeff, we've got a question from one of our viewers about the second wave. So from an epidemiological point of view, can you talk a little bit more about that and what we're seeing as far as, the curve and the number of cases, et cetera?
Yeah. I mean, I think, because this is a pathogen that the population has no immunity to, except for those who've already had it, like in this first wave. I mean, my expectation is that once we relax these social distancing measures, we are going to see a recurrence, unless we are able to do a lot of the things that the countries that have been successful. If we can implement those things, so like quarantining any travelers, and testing broadly so that we can identify any cases and isolate them, as well as making sure their contacts are placed into quarantine, and then possibly adding in broad use of face masks by the public as well. So all of these things are needed in our response for future waves, and I think there are probably going to be repeated waves of this, and I don't think it will necessarily be seasonal. I think it's just a matter of how much immunity we have in the population will determine how intense, and our public health measures will determine how intense the subsequent waves are.
And speaking of masks, Jeff, I'll just have you continue since since you mentioned that. What's the evidence for everyone wearing masks when they're outside, or at least frontline workers like grocery clerks or transportation drivers, that kind of thing?
Yeah. So, I mean, we have good evidence that, obviously N95s and surgical masks are effective in protecting the wearer against, pathogens such as this new coronavirus, which is spread by droplets. And so, I think the main restricting factor is that there is our supply. And, we're facing potential shortages even for our healthcare workers and our other essential workers. That's why the recommendation to the public by the CDC and Public Health Agency of Canada has been for the public to use cloth masks. And so the idea that, with these masks, there's like kind of two benefits. One is to protect the wearer, and also it's to protect those around them. So the idea is that if everyone is wearing cloth masks, it'll at least block the passing of droplets from somebody who may be pre-symptomatic or asymptomatic, spreading it to others if they are wearing a cloth mask. And so, there's not a lot of, there's no RCTs of how effective this is at a community level. But, I think there are some observational studies, and just anecdotally, you look at countries where they've had success in containing this, you just look at the pictures in the media, everyone's wearing a mask. And, when I'm, talking to friends, from places like Hong Kong and Taiwan, they say, it's not the government telling them they have to wear a mask, it's just everyone does. And they also wash their hands obsessively. And so I think these also are, another weapon that we can use in this war against the coronavirus.
Yeah, absolutely. Tina, what about the topic of gloves or glasses or, an eyewear protection along with cloth masks, for instance?
So I think it's really important to remember that infection prevention control in any setting is a whole series of measures. So Jeff talked about the masks, but the personal protective equipment component is only one component. And so I think what we've seen in many settings is people are implementing other measures like plexiglass barriers between grocery store clerks and customers. There's administrative controls with respect to keeping 2 meters of distance between people. So just, I think it's important to always be thinking about all of the different measures that can prevent infection. And while Jeff mentioned some of the important features of mask use, that is just one component, and all of these other measures need to be put together with them. With respect to eye protection, certainly in healthcare settings, especially when dealing with somebody who has any respiratory symptoms, eye protection would be important in addition to wearing a mask. The question of whether or not the general public, or let's say a grocery clerk, should be wearing eye protection in addition to a mask, I think again would depend on whether there's other kinds of controls that can be put in place that may in fact be more effective than the use of certain personal protective equipment. And so that would depend on the industry and the setting. The other thing just to mention about masks is that it is really critical that they are worn correctly. And so people sometimes forget that putting a mask on or taking a mask off are actually points of risk. And so making sure that if someone is wearing a mask, that they have clean hands before they put it on. And then when they take it off, cleaning hands before they take the mask off, and then after taking the mask off, and making sure that the mask is discarded immediately if it's disposable, or if it's a cloth mask, that it's only worn until it's gets a bit damp, and then it's put into a secure, whether it's a plastic bag or something else that can be put immediately into the laundry when that's possible. Because one of the concerns with masks is just that if they're seen as a talisman or something that would keep people safe, that people start forgetting about all of the other infection control measures that need to go along with masks in order to make sure that they are as effective as possible. And I would say the same thing about gloves. So sometimes people feel that if they're wearing gloves, they're more protected. But if you're wearing gloves and you touch surfaces that may be contaminated and then touch your eye with those gloves, or if you're in a grocery store wearing gloves and you handle your purse and your wallet and things that you might be touching when you get home and you don't clean those things, the gloves actually don't protect you if you're not thinking about what you're touching and if you're going to be handling those same things after you take the gloves off. So just like with masks, wearing gloves can be helpful as long as you wash your hands before you put the gloves on. Be really cognizant while you have the gloves on of what you're touching, continuing to have good practices like not touching your face. And then after taking the gloves off, immediately washing hands again. And all of those are things that need to go along with the personal protective equipment in order to make it effective.
No, that's really great, because I've certainly heard from patients that, oh, just wear a mask and you'll be protected. It does give a sort of a false sense of security, and then they tend to get closer to people and forget the other measures that you've just mentioned. So that's a really great point. Thank you.
And if I can maybe just add, I think that we know that the masks are in addition to, not in replacement of, all the other measures. And when we look at studies, for example, around SARS, many of the people who became infected, it seemed that the problem was actually the donning or doffing of personal protective equipment. So it wasn't whether or not the PPE was adequate, it was the inadvertent contamination when someone was putting on or taking off the PPE. So just to reinforce exactly what you said.
Great, thank you. Jeff, I have a question for you from the audience, viewers. So the natural history of the virus isn't still entirely clear. Does an initial infection and recovery usually confer immunity? And can it relapse, or can a person become reinfected?
Yeah, I mean, I think this is a question that everyone wants to know the answer to, but I'm not sure that anyone does know the answer to. And so, I think we can say that we have not seen many cases of people with reinfection, if any. We've all probably seen reports where people were, tested negative and then subsequently tested positive. And so we don't know if those are relapses or if there's just like remnants of virus particles still there that the PCR was picking up, or if maybe the first one was actually a false negative and then the second one, like they're actually still shedding virus the whole time. I think that's something that we need to keep an eye on. I think we can look to countries where they've had large outbreaks They can see if people are having other respiratory symptoms after they recovered, and then they could get re-swabbed to see if they are getting reinfection. I mean, I think that's a critical question that we need an answer to, but I think we don't have an answer to that yet. I mean, my guess is that based on that we haven't seen this yet this has been going on already for a number of months in places like China, that I think there's a very low probability of reinfection at this time. And that's not to say that things couldn't change over time. Maybe the virus might mutate. I don't think it has the same potential of mutating as much as influenza viruses do. But if it were to acquire that ability, then there would be definitely the risk of reinfection. So that would be like kind of a game changer as well.
So if someone has recovered symptomatically, but they retest positive, you're saying that may just be continued ongoing viral shedding then?
Potentially, that would be one explanation.
Okay, all right, great. So another question that we have for either of you is, what population surveillance methods are being used in Canada to obtain a more accurate estimate of the disease and cases in the population? Dina, do you have some thoughts on that?
Sure. So one of the things that's being done is national phone surveys, which isn't certainly accurate with respect to COVID diagnoses, but it does help to get a sense of the number of people reporting influenza-like or respiratory illnesses over time. So that's one kind of snapshot that's being undertaken. Of course, testing is the cornerstone of what all of the provinces are doing in terms of identifying cases and putting control measures in place. And so every province is currently using the test for PCR diagnosis, so a swabbing, either throat swab or a nasal or nasopharyngeal swab, and then trying to detect virus. And if it's there, obviously, then that goes into our case counts. We also, many of us across the country, are using probable definitions. So in order to take action more quickly, if we have a close contact of a confirmed case who has symptoms that are consistent with COVID, then we do take immediate public health measures around that person in terms of adding them to our case counts. And finally, there is a lot of work underway looking forward to determine the use of antibody testing. And so serology is being used in some countries, and many of our labs across the country are validating different serological test options to make sure that, first of all, they actually perform as they say that they do. So lots of companies are making these test kits, but we need to make sure that they actually can detect antibodies. And at the moment, we do not have an antibody test that can diagnose infection that's quick enough to be accurate in the diagnosis of early disease. So what we are looking at, and there is some coordination happening across the country for planning of when we might be able to implement serologic testing in the population to determine how many people have been infected. And that will help us to get a sense of whether or not there's a lot of people who maybe weren't diagnosed when they had active infection, but there's now that record of infection. And that goes back to that point that Jeff was making about then trying to understand if those people have immunity or not. There was a German study that I was reading about the other day that was interesting, that looked at serology that they had done in a town that was one of the first hit when they had their first importations from Italy, where they had several festivals and quite a large contagion rate in terms of the acute diagnoses that they had. And there was only about 15% of that population that had antibodies. So even in that population, with those festivals and the importations, they're not seeing, again, this was one particular town, but they were not seeing that the majority of their population had antibodies. So I think back to Jeff's earlier point, we do need to continue our public health measures in the foreseeable future. We can adjust them as needed, but this is going to be something that will be a threat for many months to come.
Yeah. I'm just going to add to that, my understanding is that the Canadian Blood Services is leading, coordinating across the country some efforts to do some sero-epidemiologic studies, and a number of provinces as well are actively working on these sero-epi studies. So they're either still validating the tests, or they're planning, how to their sort of sampling strategy, whether it's like residual samples or getting some sort of sampling strategy to get enough specimens to come up with estimates of the seroprotection against COVID.
Great, thank you. And another question that is somewhat related is the whole idea about the contact tracing and whether contact isolation can be done efficiently and effectively if there's a large outbreak. So for instance, as you were mentioning earlier, Dina, about the super spreader, and for instance, if universities are opened up again in the fall and it allows for first-year students to come back into residence and there's a large outbreak, how effectively can contact tracing actually be done in that kind of situation? I'll open it up to either of you.
Jeff, do you want to take a stab? I've gone first the last time.
Okay, sure. Yeah, I mean, definitely contact tracing is a critical element to the public health response to coronavirus. And we've seen, the countries that have been really successful, like China, Taiwan, Hong Kong, Singapore, Korea, they've been really aggressive in their contact tracing. And so it's about, quickly identifying cases and then identifying who their contacts are, and then contacting the contacts and ensuring that they're placed into quarantine. And so whether the traditional way of humans to track people down is the way to go, or whether we should be moving towards app-based trackers is something that's been hotly debated. There are some scientific articles suggesting that in simulations that because of this virus is the contagiousness of this virus and the relatively short incubation period that app-based tracking would be superior to human-based contact tracing. And I think there's been no studies of this yet to compare the two approaches. So I mean, my opinion is that they're probably complementary. I think you can try app-based tracking, and then you also have to have the basic bread and butter public health contact tracing as well, as kind of the backstop for people who are not using the apps properly or not using the apps at all. You still need kind of the official measures, but hopefully if some people are using the apps, we can reduce the burden on our public health colleagues, because sometimes the volume is just overwhelming. And just like, for instance, I'm actually helping out at Toronto Public Health right now with our contact tracing efforts, and we've got quite a backlog still at the moment. Sometimes people were tested a week ago and we're just calling them today, sort of thing. And hopefully we're going to get through this backlog soon.
Dina, over to you.
Thanks. I think the only thing I would add is I know that there have been questions about the fact that we're seeing more evidence around asymptomatic and pre-symptomatic transmission. And so some of those questions about, well, if you're really focusing on cases and then going after contacts, and if you can't do that promptly, how effective is it? I think, first of all, the idea that close contacts need to be in quarantine is exactly to try to prevent some of that pre-symptomatic transmission. But secondly, I think we can be encouraged by seeing what's happened in China, because the initial response in the epicenter, the original epicenter of the outbreak, was really focused, as they had to be at that time, on dealing with those who were symptomatic and making sure that they were isolating those who were symptomatic and quarantining close contacts. And they were able to achieve a reduction in transmission rate. And certainly now we see in that epicenter that they have been doing more testing in the population, even of people without symptoms, and they are finding evidence of some infection. But again, I think we need to remember that it's important, depending on the epidemiology of a particular location, we have to focus on getting the symptomatic cases under control, while being mindful of that asymptomatic, pre-symptomatic transmission. But I know here we've heard lots of questions about testing people who have no symptoms, and that makes sense in certain contexts. But we have to be really focused on getting those people who are most infectious, people who are symptomatic, tested, and then tracing those close contacts as our point of first priority.
So then, we've heard a lot in the news about, where there are outbreaks, for instance, in nursing homes. Then, it begs the question: should every healthcare worker in a setting like that be tested, say, weekly, even if they don't have symptoms?
Yeah, I'll go first, maybe. Yeah, I mean, that's a very good question, and I think the issue is, what is the testing capacity? And so, here in Ontario, we've got capacity up to, like, I think 16,000 tests a day is what they're saying. But if you look at, how many residents there are in long-term care facilities and retirement homes, and then how many staff who work in them, is it even possible to test so many people? Or might it not be necessary if they're all wearing PPE? If all the staff are wearing PPE every day, is that adequate to reduce the risk of infection? I mean, ideally, we would capture all the cases, in staff, especially, so that they cannot infect the residents. But is testing the right strategy, especially with false negatives, and the approach to testing asymptomatic folks is quite challenging. So I'm not sure what the answer is there. I'm not sure that there's a perfect solution, but I think that a multifaceted approach is what we'll most likely need.
And that certainly makes sense, as our our whole approach has been multifaceted between hand washing and social distancing as well. But Jeff, if so, a question from the audience has come up is with respect to viral load. So how much, sort of on both ends, how much viral load is required to actually cause disease, and how much IgG, for instance, does confer immunity? Is there a load, sort of point on either end for cause and for immunity?
Yeah, sorry. Unfortunately, I don't know the answer to those questions. Okay. I don't know if Dina has any answers to those.
I don't have the quantitative number answers, but I can say that what we know about the virus is that, unlike MERS and SARS, where the viral load in someone who was infected got steadily higher and was highest in later courses of the illness, it seems like with COVID, with the SARS-2 coronavirus, it's higher in the early stages of the illness. And that's relevant because, of course, that makes it harder to stop the spread. We also know that when someone it seems to be, there's some early evidence, and this is yet to be validated, but early evidence that if someone is exposed to a lower initial dose of virus, that they may have a lower chance of going on to get severe illness. So it seems like the initial dose, and again, I don't have the quantity or kind of the number cut off, but it seems like the higher the initial infective dose, the greater the chances that person has a severe illness. And these are all things that are being investigated right now to get that more certain answer. So I think we can look to researchers to give us better answers on these things going forward. But what it means in practical terms is that the more that we can reduce the possibility of being exposed to large doses of virus, we've talked about all those mitigating strategies, even if somebody is exposed, the lower the dose that they have, the less chance they have of having severe disease, it seems, at this time.
And that certainly does make an intuitive sense for sure. As well, Jeff, any further comments on that?
No, I think those are great points that Dina raised. I don't have any further comments there, but they make sense.
Okay.
Yeah.
There's another question here about, Dina, you had mentioned about these new sort of test kits that are coming out, and one of our viewers has asked about the Spartan bioscience testing devices that can confirm a diagnosis in 45 minutes. Any comments from either of you about the use of these rapid diagnosis test kits?
So I can speak a bit about, in Alberta, we have ordered several of those machines, and My understanding is these are relatively small machines that are portable, so they can be placed in locations where the regular access to lab testing might be a challenge, and that each of the machines you would need to get a kind of a little test kit, one test kit for each individual. And my understanding is these are machines that are designed to process swabs. So these are PCR machines, and they can run, as was said, one test kit in about 45 minutes, roughly. So these are not machines that are going to help us with mass testing necessarily, because it does take that 45 minutes to get the results. So it's actually much more efficient when we're doing large numbers of tests to get those back to our labs and run them on our mass machines. But where there are remote or rural settings where transport time to get swabs to the lab is a challenge, or where you might have the settings where knowing an answer within 45 minutes is going to make a critical difference, that's where we're looking at deploying those machines. So again, it's about a strategic deployment of these, but these do need to be used by somebody who has training. So these are not meant to be used by the general public or someone who does not have the training to operate technical lab equipment. And I think that's one of the things we've been hearing as different lab tests come out and there's media about them. People feeling like it might be as simple as, for example, a pregnancy test that you can buy at the drugstore, and you would go and get this, and that any member of the public might be able to do that. And maybe down the road, maybe we'll get there, but these machines do still need to be a part of a full trained workforce. And the other critical piece about them is that in Alberta, and I think across the country, positive test results for COVID are legally reportable to public health. And so we need to make sure that as these machines are deployed, there are mechanisms for getting positive results reported back to public health. And that because these machines aren't necessarily hooked into our lab information systems, depending where they're deployed, that's just a really critical element so that we can do all of the contact tracing we talked about earlier.
Excellent points. Jeff?
Yeah, Dina covered all the points. I have nothing to add other than hopefully, we'll have, the goal eventually will be to have, rapid, point of care serological tests, like a pinprick, and then it's like IgM, IgG, and then you can give the answer like a pregnancy test. And that's, in the future, I know there are many companies developing these tests. Some have been released and maybe approved, but I think they require validation still.
Excellent. Thank you. So I'm going to shift a little bit over to a couple of questions that have been coming in around outbreaks and incidents, and we're certainly in certain provinces we're seeing higher rates in certain locations like nursing homes compared to other provinces, and just wondered if you can comment on some of the factors that contribute to the disparity between these in the numbers that we're seeing.
Sure, maybe I'll go first, and then Dina. We're talking about a very vulnerable population. These are frail, elderly, often who are there. They live in these congregated settings where they're often eating together. The staff often don't have access to PPE, and they don't have training on using PPE. And they're often working at multiple locations. And so all of these are kind of like a recipe for disaster when we're talking about a pathogen like COVID. And so, hopefully that with the measures being put into place now where, they're saying that, staff should only be working at one facility. We're hoping to get PPE out to them so that they can use the PPE. And then, not allowing any more communal meals. Everyone has to have their meals, in the room. And to keep them as separate as possible. Hopefully these things will help. Some things are going to be challenging. What about, shared rooms where there's 4 patients to a room, 4 residents to a room. And so, I think these are a lot of things that, this whole sector has been, underfunded chronically. And I think, unfortunately, this is the consequence now at this point. I'm not sure what else, we can do. I think that I saw some of the suggestions from viewers of, maybe doing pool testing of the staff. And I think that might be a viable solution to conserve the testing capacity. And then if there's one person, one batch comes back positive, then you test those group individually. I think that's something that's worth exploring, and I'll try to pass that up to people that I can speak to at the point.
Yeah. Well, anything like that would be helpful. Dina, what's your perspective?
Sure. So I don't know if part of that question was also related to kind of looking at different provinces across the country and different experiences.
Yes.
I would say that outbreaks in continuing care facilities are a significant concern for all of us across the country, and some provinces have had more than others. I know that different provinces had the onset of their local transmission at different points in time. Alberta's a few weeks behind Ontario, Quebec, BC, with respect to when we started to see our community spread. So we have perhaps seen less outbreaks so far, but we are seeing outbreaks in Alberta in those settings, and they are settings of extreme concern. The one thing I would add to what Jeff said is that I think that there's a real dilemma with respect to vulnerable people in long-term care and continuing care, depending on how long this goes on, and we do expect that it will be going on for many months. There's sort of that quality of life, quantity of life dilemma about, I've been receiving lots of messages from people who have loved ones in these facilities, and they're really concerned that people have no visitors anymore. They're not able to congregate at all, even prior to an outbreak being declared in some cases. And they're advocating for their loved ones about, how do we weigh the quality of people's life in these places against the risk of a deadly infection? And so I think that's something that more attention is going to be paid to in the coming weeks and months as we, have conversations with people who live in these settings, with their caregivers, their loved ones, with staff. How can we keep these people as safe as possible, but also not deprive them of some of the things that give them joy, that bring them comfort, and how do we balance those tensions out? So I think that's going to be a really important conversation.
Yes, absolutely. And that also brings up the other point of the whole stress on our healthcare system in general, and the impact of the longer, as you say, if this is expected to go on for many more months, the economical impact on people who are losing their jobs and their wages, and then the mental health impact on people who are isolated and are experiencing, symptoms of depression and anxiety. And do you think that, public health units are looking at this or are equipped to deal with that, or are there discussions going on about, approaches to look at this in the coming months? I'll open it up to either.
Dina, do you want to go first? Do you have?
Sure, I can take a stab at this. So I would say that this has to be an all-sector response, and that it can't just be about kind of that public health and virus spread suppression. That's critical. It's something that obviously we're focused on, but we have to be paying attention to the impacts across all society. And in Alberta, that's been something that's been very important, that we have been working with our mental health, with our addictions sectors, making sure that we have plans and supports in place for people. With respect to the economic impacts, again, absolutely, this is something that has a huge health impact. So when people lose their jobs and they don't have income support, that absolutely impacts their health, and the long-term consequences of the pandemic are significant. What we know from watching countries around the world is that if we don't put public health measures in place to prevent the spread, and spread happens widely, there are impacts on the economy. Even if we don't take these measures, widespread infection and high death rates and overwhelming our health system will paralyze our economy anyways. So what we have to do is try to, again, continually balance out the public health measures that are sufficient to control spread, but to keep enough of our economy functioning that we're not having an undue impact and hardship on people. And so that's a dynamic balance, and it's something that is multi-directional. I know earlier there had been reference made to some countries that have been successful in controlling early spread, but I understand from some conversations with colleagues in Singapore that although their initial efforts were very successful in preventing spread, with the increase in returning travelers, they actually have seen an increase in community transmission. And I was told last week that they were actually looking at having to restrict movement and put in some economic shutdown measures to prevent ongoing community transmission. So I don't think this is a one-way direction. It's a dynamic balance, and we need to make sure that we're supporting people throughout, and especially healthcare workers. It was really clear in SARS that the impact on workers who are at the front lines of this response was only partly about physical risk, but the mental strain was significant, and we need to make sure that we're supporting healthcare workers and making sure that they have mental health supports and psychological supports to get through this.
Wonderful. Thank you, Dina. Last question I'm actually going to pose to Jeff, because I know it's on everyone's minds. Vaccines. When? How soon? Is it going to be available? Gradually?
Yeah. So, the other day I saw on Twitter that, a colleague emailed it to me. There's actually a tracker that's put out by the London School of Hygiene and Tropical Medicine, where they've got they've listed 60 candidate vaccines and showing where they are in the production sort of pipeline. And so there are, I think, 3 that are now entering phase 1 trials, and the rest of them are still in development. But I'm hoping that one of these 60, or at least one of these 60, will work. And they're using different technologies. And so, I think there's a lot of groups that are working very hard to develop a vaccine. But I think, everyone says, best case scenario, it's going to be 12 to 18 months before we have a vaccine. And that's because we have to do all the clinical trials to ensure efficacy and safety of a vaccine. And then you have to take into account that, they have to get approvals, and then they have to start mass producing. And so it's not like overnight that we'll have capacity to vaccinate billions of people. But I think it's going to be some time. And my guess is that, it's going to be like kind of the efforts to produce a vaccine will kind of be nationalized, in that, I think if there's a multinational company that produces a vaccine, I have a suspicion that a country will say, no, we're going to keep all of this supply to ourselves. So I'm hoping that, there's at least one Canadian company that I'm aware of that's trying to produce a vaccine. So hopefully Canadians will have, first access to that. But I think this is something that's going to be hugely tricky. Once there is a vaccine that's produced, how are we going to determine who's going to get it first? Where is it going to be distributed first? Which populations are we going to prioritize? Will we have a test that identify those who are already immune, and then we can, focus on those who are not yet immune to prioritize the vaccine. So all of these things need to be, are going to be playing out in the next, 12 to 18 months. And then the question of what is the likelihood that these vaccines are going to work? I think if you look at what vaccines we have available against respiratory viruses, we're talking about like measles, mumps, and influenza. And so, the measles and mumps vaccine is very effective. Influenza vaccine is less effective, let's just say, 40 to 60% effectiveness, and we're already, happy. How effective is a coronavirus vaccine going to be? And how long will it take us to make it? Because we've been trying to develop RSV vaccines for, my understanding is it's been like decades, and we haven't had much success in RSV. There have been some candidates, and they have gone to clinical trials, but my understanding is that RSV vaccines have not yet developed an effective RSV vaccine. So I'm a little bit pessimistic about the likelihood that we're going to have a coronavirus vaccine anytime in the near future. So it might be that we'll have, immunity before we have like broad, widespread immunity in the population before we get a vaccine.
Very much appreciate. That's a very insightful perspective, and I think that a lot of people have been wondering about. So I'd like to, on behalf of CFPC, thank you both very much for taking your time out of your busy schedules to join us, and just invite you to make any final parting comment advice or anything that you'd like to say to our audience before we close down. Dina?
So I'll just say thank you because you guys are on the front lines and you're dealing with this. Your patients have questions and you're doing an amazing job. So I just wanted to say thank you.
Thank you, Dina. Jeff?
Yeah, I mean, I didn't mean to end my comments on such a down note. I think, you know, the RSV question, vaccine is like, not as many groups are working on that. So maybe with this coronavirus one, like with everyone focused on this, maybe we will have a vaccine sooner than later. But I hopefully we will have one soon. And other than that, I just want to repeat Dina's comments to thank, I work as a family physician myself. I just want to thank our colleagues that, to keep people safe on the front lines and to keep caring for our patients.
Thank you both. And thank you to our viewers for tuning in. And just a reminder that if you have to claim your credit by clicking over the link, that'll be open until Sunday. And if you're interested in joining the My Group's conversation platform, we do encourage you to do so. And on the next slide, we'll show you the topics that are coming up. Next week, we'll be having our webinar at noon next Thursday on the topic of the elderly and long-term care residents during this pandemic. And then following weeks will be on emergency care in the hospital setting. And then our evidence-based webinar will be in the week following that. So again, thank you to everyone. Thank you to Brian Cote and our team in the background. And again, to our fabulous speakers for joining us today. Take care, everyone, and stay healthy.